Right, shall we get started? So welcome everyone to tonight's webinar, What to Do in an Emergency. We are recording this webinar for us to be able to signpost to people when they come to us asking questions about what to do in an emergency. I'm Alex Johnson. I'm the co-founder of Duchenne UK, but I'm also mom to Jack, who's 14 years old and living with Duchenne muscular dystrophy. I think first, just as a bit of patient perspective, I myself have found, well, me and Jack have been in A&E twice this year, and I think at that moment in crisis, I think you can be the most well-informed parent, but everything you think you know goes out of the window and you begin to doubt yourself. So I was so grateful that I did have the Duchenne in case of emergency app on my phone, and I was able to give it to the nurse and to the doctor, who then knew to look for things like fat embolism syndrome. And then last week, unfortunately, Jack became ill with what started off just like a normal cold for 2 days. But then he actually got really, really sick very, very quickly and developed a temperature. He was shaking, he was vomiting, he was crying out with pains in his calves, which has never happened before. And we did have to give him a stress dose of steroids, which is something I've never done before. So, I had to read up and remind myself of what the protocol was. I think at the moment, as parents, we are all concerned about the NHS, and I think it's been reported in the media that it is in crisis, and we're worried about the nurse strikes and the ambulance strikes, and how can we best care for our children in emergency scenarios. So tonight's webinar is hosted by the DMD Care UK team, and what DMD Care UK aims to do is make sure we make available the best care to all patients, no matter where we live. So we have 12 working groups that aim to look after everything from our hearts to our lungs, to our minds, to our bones. And one of the working groups is the emergency working group, and I'm delighted tonight to be joined by Dr. Michela Guglieri, who very kindly leads this whole project from a clinical perspective, Dr. Jarod Wong, who is the lead for the bone and endocrine working group, and Kathy Turner, who's our wonderful program manager. So I'm going to hand over to Michela, who's going to tell us what to do in an emergency.
Hello and good evening, everyone. Thank you, Alex, for the introduction. And just to say, I'm Dr. Michela Guglieri, I'm a consultant neurologist and work at the Walton Muscular Dystrophy Research Center. And I'm a coordinator of the DMD Care UK project. But in general, a lot of my time at work is dedicated to the care and clinical research with patients with Duchenne muscular dystrophy. It was very difficult to say what to do in emergency and try to cover everything. And it's something that the emergency itself, in a way, is unpredictable sometimes. So before starting and going into the details of specific situation where you might find yourself in any circumstance, I really just want to give an overview. And I think that with the Christmas holiday coming up and the feeling that the neuromuscular team might not be as available as usual, or you might struggle to get in touch with any medical staff, I just wanted to point out a few key points that you can really manage and be confident in how you report things. And the first message is always say, be confident. You are a parent and you know your child. So a lot of the question that parents come to me sometimes is related to say, how do I know how the child is? Is severely ill, is moderately ill, is mildly ill? And sometimes these are only definition, and then the reality is that you have a child, and is a child that is tired because it's the end of half term, is you have a child because it's excited about Christmas, but you know your child, and you know when you think this is not simply a cold or not a simple runny nose, and be confident in that. Don't question yourself too much. It's just something that as a parent, you have the feeling on that. And if sometimes you are not sure, means that maybe it's not so severe because you're not very sure. And they're always thinking about it's never in one shot call. Reassess the monitor for a few hours, monitor for a day, and see how does it go. Children usually have the strength to react to things, even if they have Duchenne, even if they are on corticosteroid. But if you feel that is not getting better, initially you have some concern, but you were not sure, but after 2 days you think it's still like that, that is a real concern. If you are in doubt, ask for the medical advice. I mean, do not torture yourself about, oh, is yes or no. It's just ask. And sometimes the medical advice is not reachable straight away. So if you give yourself a little bit of time to reach out someone, is actually make you feel more reassured. One key message, and this is really for children, but also adults, because we now continue corticosteroid even after the loss of ambulation or after in adulthood, is important message. Always, corticosteroid should never be missed. And this is a statement in a way. So we know that, and Jarod will spend his talk talking about the implication of being on high doses of corticosteroid and the risk of adrenal suppression. The general message is that you should not miss corticosteroid. And they might be missed because the child or the person is unwell, and therefore you cannot really take the medication. You missed it because you forget it's Christmas and there's a lot of things happening in life, or you go away and you think about the most important thing that you need to remember is your passport if you leave the country and the corticosteroid for your child. This is critical. If you miss the dose, the point is that they should not be missed for more than 24 hours. So if you realize, oh, I didn't take the corticosteroid in the morning, give it at a later stage, the later hours, if you can still take them. But also ensure that you have a steroid emergency plan. Again, Jarod will talk about this, but just for you to be familiar before, for example, the Christmas holiday, to say, if the child cannot take corticosteroid for whatever reason, what am I supposed to do? And this is part of the webinar today to really focus and give you some information about this. Next slide. And then a key point, just really this is in general for everyone, whatever is the reason that you need to go to hospital, whether it's a E&E or is an hospital admission, there are a few things that you need to remember. First of all, take the medication with you. Sometimes you panic and you don't remember, and you might remember the name, but you don't remember exactly the dose. So sometimes just to grab the bag with all the medication and take it with you is the best things to do. Or otherwise, you take a picture of the prescription on your phone, have the list of medication with you, because this is very useful for the medical staff that need to take care of your child in a E&E. Always, always, in any format or way, remember that to highlight that the child is on corticosteroid. Can be through a bracelet, can be through you that you say, I will never forget about that, or can be just a card, or can be the DMD emergency app. In whatever format, it's important that one of the things that you always need to remember is to say, he's on high doses of corticosteroid. This is important. Unfortunately, there are in some circumstances, people might not be aware that the Flaza is a corticosteroid, and therefore this is something that is important that you highlight. If you can, take your last clinical letter and check in the last clinical letter what is in there. Is there any reference to his respiratory function, his cardiac function? That is important. And if you have it, just wrap it in together with the medication. But I think that all of this, in a way, is summarized in the DMD emergency hub that Alex mentioned already, and then Kathy will present later on. And this is how do I track all of this information without even if I forget to grab that back. The DMD emergency hub was really created with this aim to try to have these 3 instructions clearly stated in an easily and accessible way. One important thing is probably for the older patient that might be on ventilator, on the cough assist, or have a cough assist machine. Remember that if you go to the hospital, you need to be admitted to the hospital, or you might need to stay overnight in the hospital for a chest infection or for something. Please remember to take the ventilator and the cough assist machine. That is very important because it might take a few hours otherwise to find the ventilator of the cough assist machine, and your child or yourself is used to your own ventilator, and in a distressful situation it's much easier to have the equipment that you are familiar with. Next slide. Then I wanted to mention just a few situations that probably are the most common one, and then maybe your question about what to do in that specific case obviously is not comprehensive, and hopefully we'll have a session at the end with question when maybe you have additional circumstances that you want to ask what to do. In general, you need to consider that if a child or a patient with Duchenne muscular dystrophy has a cough and a cold or an infection, is still a child with a cough and cold and infection. So the routine care, so keep the child well hydrated, try to control the fever with the paracetamol and have some rest and warm is true for everyone, including children with Duchenne. And this is a priority and this is very important. Jarod will give the details about it, but it's important to notice that if you have an acute infection, your child or yourself might need a higher doses of corticosteroid to help your body to cope with that infection. And therefore, it's possible that you might need an oral or a intramuscular stress dose of corticosteroid. And I don't go to the detail of this because Jarod will cover this. There is also a lot of discussion about should we have access to antibiotics, and I know that GP are very reluctant to prescribe antibiotics for a risk of potentially what they call is a resistance. So if you continue to take the same antibiotics, at one point your body will adapt to that antibiotic, and that antibiotic will not be effective. In general, for patients that have a compromised respiratory function, so they have either a ventilator or they have a clear reduction in their forced vital capacity, they should have a early access to antibiotics. And this is important because even if there is a viral infection, because they are not able to clear their secretion as well as a healthy person, is much more likely that that secretion go over-infected by a bacteria. It doesn't necessarily mean that a young boy with Duchenne muscular dystrophy that is fit and well, has a valid cough, need antibiotics as soon as he has a little bit of a runny nose or a cough. But if you start to have fever, has a productive cough, have an early access to antibiotics is important. In general, this is not really for the emergency situation, but just as a general guidelines is that it is important that children with Duchenne muscular dystrophy has up-to-date vaccine according with the national guidelines. Next slide. There is a lot of discussion about COVID. Is a wave when there is COVID and when it's a little bit quieter in terms of COVID infection, and what do we need to do? There are some guidelines. This is the link that you can find further information, but also on the NHS website, there are information about COVID infection in children and what to do. In general, I think that is reassuring that after 2.5 years with COVID, we have also learned that in general, boys with Duchenne muscular dystrophy seems to cope well with the infection, and we do not have a lot of patients that has developed severe complication. And is as for the whole population, children or adult with Duchenne muscular dystrophy that has a compromised respiratory function or severe cardiac disease are at higher risk of developing complication. And therefore, in the national guidelines suggest that a treatment in general with monoclonal antibodies is recommended with the patient that are on the high risk category, that is patient that has compromised respiratory function and are ventilated or severe cardiomyopathy, but also if they are on corticosteroid, although the dose is higher compared to what we usually prescribe in Duchenne muscular dystrophy. So depend a little bit of the area, you might be offered treatment with monoclonal antibody or not. I think that is important to monitor the child. If it does not fit the national criteria, is to monitor the child, but if he's severely unwell, raise your concern. The way to do that is that you need to have a lateral flow test confirming the infection, and you need to register on the gov.uk website in order to have access to any treatment. Next slide. Just to add a few points, that completely different system is the gastrointestinal illness. And I think that one point that I want to mention is the constipation. Constipation is very common in pediatric and is very common in boys and adults with Duchenne muscular dystrophy. And the reason of that is for different reasons, but it's also that the reduced mobility can also impact the bowel mobility. can be very severe, and if it's severe and not treated, can lead to severe complication. So monitoring the bowel movement is important. In general, physical activity, good oral intake of fluid, and a good balanced diet that includes fruit and vegetables in general help with the bowel mobility. But if the constipation persists, is not controllable by the diet, or is not controllable by the medication that he has been, the child has been prescribed with, and especially if it's associated with abdominal pain, you really need to ask for a medical opinion, because can become, can complicate. Next slide. Again, for a gastrointestinal point of view, important to notice that vomit quite often require the stress dose of corticosteroid for two reasons. First of all, if he's vomiting, probably the child is not able to take a corticosteroid orally, so he cannot take his background corticosteroid, which is a problem. But also, if you have persistent vomit, is a illness that might require an extra cover, an extra dose of corticosteroid. And again, Jarod will discuss this. Another point that I want to mention is that children or adults with high doses of corticosteroid have a higher risk compared to the healthy population about gastric ulcers and therefore a bleeding in your stomach. As a general guideline, we should avoid non-steroidal anti-inflammatory drugs. That usually is the ibuprofen. If we need to take ibuprofen for an acute pain, make sure that it's taken with food, so on a full stomach and not on an empty stomach, and try to avoid it to take the ibuprofen for several consecutive days. If it's required, discuss with your GP, because your child will need something to protect his stomach. That is a gastroprotective treatment. And that gastroprotective treatment should be initiated in case of any epigastric, so a pain in the middle of the stomach. And if there is an acute pain in epigastric, so it's really just in the middle of your abdomen, of your tummy, I think that is important to ask for urgent medical advice. Next slide. Just completely different topic. I just really give an overview of what I think is the most important one, but it's about fractures. So we know children fall, and because they are on high doses of corticosteroid, they have a higher risk of fracture, and this means both long bone fractures and vertebral fracture. Before going into the management of the fracture itself, I just wanted to point it out without creating any panic, but Alex also mentioned this, is the potential risk of fat embolism syndrome, which seems to be higher, a more frequent complication in following a fracture in boys with Duchenne muscular dystrophy compared to the healthy population. Just to let you know that fat embolism syndrome is reported, but usually is reported following a severe fracture or a severe trauma. And what we have noticed is that children and adults with Duchenne muscular dystrophy can have a fat embolism syndrome even after a minor trauma or a fracture that is not detected on an X-ray. So you are discharged because there is no fracture, and actually you still are at risk of fat embolism. And what is important that is after a fall, or obviously after a fracture, but even after a bad fall, be careful to monitor symptoms of the FES. That could be difficulty with breathing, either feeling out of breath or shortness of breath, or having a very rapid breathing pathway, or an increased heart rate, or a sudden onset of headache or chest pain. And surely is change in behavior that can be confusion, disorientation, but also that they behave strangely in a way that you are not used to see them. All of these are, and surely if they are more sleepy and they can't really wake up easily. These are all symptoms that need urgent follow-up, and means to go quickly to the emergency department and highlight the potential risk of FES, but you need to be carefully monitored. Next slide. In terms of, in case of any surgery is required following a fracture or following anything else, I think that is important to highlight. Always communicate the diagnosis. Always, again, with the app, provide an update about your child or your respiratory function and cardiac function, because the management in terms of surgery and anesthetic risk really depend on your respiratory function and heart function. The patient on long-term treatment with corticosteroid will require the stress dose of hydrocortisone. And again, Jarod will provide the detail. In general, the anesthetic need to be used with caution. And I think that it's important to say, if you need an anesthetic, you still need an anesthetic. But it's important that the anesthetist is informed about your medication, your diagnosis, and the respiratory and cardiac function. Local anesthetics are not usually a problem, so there are no concern for that perspective. But if you need a general anesthetic, as a principle, they took what we call the total intravenous anesthetic technique. So is a full general anesthetics with no gas and air is preferable because it's much more controllable from, again, the respiratory point of view. And there are some medications that are not routinely in use in the UK, but are what we call the depolarizing muscle relaxant that should always be avoided in DMD because can cause complication. And this is clearly stated in the app, so you don't need to remember this strange name, but it's just highlight that there are some anesthetic risk. Next slide. If the child is admitted to hospital, other key point in general, so the use of oxygen, just the oxygen mask, should be limited. I cannot say that can never be taken, but should be limited and never for prolonged period of time, or for patients with a compromised respiratory function, because can actually mask the lack of respiratory function, and therefore mask symptoms of a higher level of intervention that are needed. I repeated this twice, both for the hospital admission, but also for the management of pain, about opioids. So codeine is very common and everybody can buy it over the counter, is a cocodamol, or codeine itself should be avoided. It should be definitely be avoided in patients with compromised respiratory function, but in general, some patients can have a very slow metabolism of codeine, and therefore they can have a respiratory suppression even if their respiratory function, they are not, for example, ventilated. In addition to that, codeine can cause a severe constipation and therefore should be avoided. And always remember that patients, especially the older one with Duchenne muscular dystrophy, are quite often wheelchair bound, and therefore respiratory problem and cardiac problem might not present with symptoms that any clinician in A&E would expect. So they might not have a respiratory distress, means feeling out of breath, but still their respiratory function can be severely compromised. And these will need to be highlighted. Next slide. In terms of pain, how do we manage pain? Again, acute onset of pain, especially of back pain, that is after a fall, or after just even after a transfer, or after a car accident, in very lot of situations, could be a vertebral fracture. And the strange thing is that if we have a vertebral fracture, we'll have a lot of pain, we'll be in bed and could not be moved. Patients with Duchenne, they report pain, but the pain might not be so severe to make clearly there is something dramatically wrong, but still put attention on that. The same is for leg. You need to consider that when patients are on high doses of corticosteroid, they might feel the pain less. So the high doses of corticosteroid might hide a painful fractures, and therefore you might minimize a pain, or the patient can minimize the pain. As I mentioned, in terms of pain relief, paracetamol can always be used. If you used ibuprofen, just try to have on a full stomach and not on repeated day. In that case, ask for an medical opinion for gastroprotection and limit the use of opioids. Next slide. I just wanted to, in a way, conclude with also the mental health issues. This is a tricky one because we do not really have a service. And I think that is important to highlight that if a patient with DMD presents with an acute mental health issues, is exactly the same as someone without DMD. And I just put here the link of some services that are available. These are for urgent mental health issues. It's not about chronic. And I think that Kathy will mention a little bit more about more long-term mental health issues in Duchenne and what we are working on. And I think with this one I finish. I just wanted to mention one thing, that I apologize because I wanted to put one slide in terms of patients that are in clinical trial. These are a little bit a different situation in emergency because there is probably some protocols that are dictated by the trial itself. So if you are in a clinical trial before any holiday, make sure that you have a contact person to get in touch with in case of an emergency. And this usually is the clinician that follow your child in the trial, because in case of an admission, you might need to get in touch with someone who provide information about the investigational drug that the child is on.
Fantastic. Thank you, Michela. We also, I just want to point out, we do have the chat function and the Q&A function. So if you've got any questions, please type them in the chat or in the Q&A, and we'll do questions after the presentation. So I'd like to now introduce Dr. Jarod Wong from Glasgow University Hospital.
Thanks very much, Alex, and thanks to everyone for attending tonight, just to get ourselves familiarized ahead of the winter months about emergency, and I'm going to talk about adrenal insufficiency. Next slide, please. Sorry, next slide. This matter relates specifically to boys and men with DMD on long-term steroids, but also relates to people, boys or men, who've recently discontinued steroids. If your son or you have stopped steroids for many years down the line, this is not an issue that you need to worry about. So let's go back to a little bit of basics so you understand the matter of adrenal insufficiency, and I'll give you some very practical tips that hopefully you will remember with the aid of the app. So the adrenal glands are two glands that sit on top of the kidneys. They make natural steroids or steroid hormones called cortisol, and cortisol is very important to help us keep well from a day-to-day basis, but also to cope with stress. And that I mean emotional stress, but also particularly stress of acute illness and significant trauma. The adrenal gland and its ability to make steroid hormone is controlled by a signal that's secreted by a little gland that sits in the middle of the brain behind the nerve that supplies the eye, called the pituitary gland. And I call the pituitary gland the master conductor or the master regulator of lots of hormone control in the body. Pituitary gland secretes this signal called ACTH, and normally ACTH tells the adrenal glands to make these steroid hormones called cortisol, which we make. Next slide, please. So all forms of artificial steroid medicines like prednisolone, deflazacort, and also vamorolone, which whilst not routinely available yet, there are very, very small numbers of boys with DMD who's part of the clinical trial. These are artificial forms of steroids. And with the steroids, medicines are taken for more than a month, which in boys with DMD, it happens. This actually switches off the master regulator, i.e. the ACTH signal. And as a result, the adrenal glands, which functions normally in a boy with DMD, but because the switch is turned off, it stops making cortisol. So the other way I explain to my young boys in clinic is that you imagine that your bulb is working, but there's something wrong with the switch itself, and therefore there is no light. So in that state, we know these patients have adrenal insufficiency. Sometimes the term adrenal suppression is used. I sometimes use the term sleepy adrenal glands, particularly where I'm talking to much younger boys with DMD. But the effective medical term that we tend to use is adrenal insufficiency, or sometimes use adrenal suppression. Next slide, please. So let's go back to what happens normally with steroid hormones or cortisol during illness. During moderate stress, the adrenal glands in any one of us makes about 3 times more as much natural steroids or cortisol. And this is, for instance, a viral illness where someone's feverish or feels very hot, and that's to help to cope with the infection and fight the infection. On the other hand, with major stress, for instance, somebody's very, very sick, if you develop sepsis or meningitis or needs a major operation, the the adrenal gland will make at least 5, if not up to about 10 times of the normal steroid hormone or cortisol to just cope with the stress of that illness. But of course, we know that if one takes steroid medicines like prednisolone, deflazacort for a long period of time, the gland does not produce these extra steroids because it has gone to sleep. Now, the prescribed dose of prednisolone and deflazacort is actually very high. It's at least about 5 times more of the production of natural steroid hormones. So in some way, it's actually probably okay to cope with at least moderate stress, but there has been some changes in our understanding. And next slide, please. Unfortunately, it's prednisolone to some extent, but more so deflazacort as well, is very short-lived. So whilst you take the deflazacort once a day and it seems to help with the muscle outcomes, it doesn't lead to sustained level of cortisol over a 24-hour period. And during an illness, of course, you want to have enough cortisol to cope with the illness all throughout the 24 hours. And therefore, with a moderate illness, and I'll come back to that to give you a bit more ideas of what moderate illness is, we now, at least over the last couple of years, have started recommending that an oral steroid sick day dosing is needed to help the young boy or the man with Duchenne to cope with the illness of moderate illness. Next slide, please. So let's talk about the major stressors, so situations where we're a little bit much more concerned about, and perhaps we need to think about giving these stress dose steroids in a different way. So when somebody's very ill, drowsy, very floppy, for instance, when there's suspected sepsis or meningitis, when there's non-blanching rash, where there's some kind of a vomiting or diarrheal illness, so it could be gastroenteritis, but the young person can't take the usual steroids, let alone the oral sick day dosing. Sometimes following the first infusion of bisphosphonate, a small number of boys can be quite unwell and with vomiting that doesn't seem to settle. And in other stressful situations, for instance, a fracture of the long bone when there's a lot of pain, when you need to call an ambulance, or if prior to an operation. So steroids need to be given in a different way other than by the mouth. Next slide, please. And in this instance, if you're at home and you encounter some of the situations, obviously not just a planned operation, ideally an injection of steroid in the form of hydrocortisone should be administered prior to attending to the hospital, either by the family if you're trained or by the attending emergency paramedic staff. The key to when you contact an ambulance is actually the key term, and Alex talks about how sometimes in an emergency you forget what you're saying. I tell my parents to clearly tell ambulance staff or medical staff that their boy or they have Duchenne muscular dystrophy, but the key words is that if you remember adrenal insufficiency, that's helpful. But if you don't, sometimes the term that paramedic staff respond quite well to is that you're steroid dependent, and that you fear or you're worried that that young person is having an adrenal crisis. Next slide, please. So an adrenal crisis is when the stress of that illness or that trauma is so severe, and there's insufficient cortisol in that person to cope with the stress of that illness or that trauma. So as a parent at home, what are some symptoms you look out for? One of the key is that your boy is quite pale or just a really horrible color and very sleepy and drowsy, okay? Vomiting that's not settling, and that could be the underlying illness itself. Quite an unexplained tummy pain, unexplained headache. But another good sign is that if they feel quite lightheaded when they're standing up in an ambulant boy, or in a boy who's non-ambulant, when they're trying to sit up, they feel a little bit lightheaded and faint, because when you have an adrenal crisis, blood pressure is lower. So these are good signs to think about in the context of illness that maybe the boy with DMD is tipping into adrenal crisis. Next slide, please. So let's come back to the moderate stress. In ambulant boys, the dose of prescribed steroids is usually sufficient to cope with moderate stress, like I said earlier. In the non-ambulant boy and adult, some clinics actually reduce the dose of steroids slightly and might not be up to about 3 times. And I already discussed the rationale that since the last few years, we're now recommending that all boys with DMD during moderate stress or illness, that oral sick day dosing or oral stress dose should be administered to ensure that there's sufficient cortisol to cope with this moderate stress over the 24-hour period. And as part of the work of DMD Care UK, the regimen that we recommend is oral hydrocortisone 4 times a day, as part of, on top of the usual steroids. But if you've been given a personalized plan, please do stick with that, because there's several ways of actually doing it. But the idea is that the young person needs to have steroids a few times a day. If it's prednisolone, twice a day is sufficient, and I'll come back to that in a bit. Next slide, please. So summary points: if boys with DMD on steroids for more than a month, they should be considered to have adrenal insufficiency, major stress, think of an injection, or in the hospital setting via drip. With moderate stress, oral sick day dosing is now recommended, either as extra hydrocortisone or prednisolone twice a day. If you've stopped steroids recently, this also needs to be considered, as adrenal function can take up to 6 to 12 months to fully recover after discontinuation of steroids. Next slide, please. So let's talk about this color-coded system, because people tend to ask me what's minor illness, what's major illness, and what's severe illness. And this comes from some work and guidance as part of a national guidance of management of pediatric adrenal insufficiency launched by the British Society of Paediatric Endocrinology just last month. With minor illness, and we're talking about mild cold and runny nose with no fever, the boy with your son is still fairly happy doing the usual stuff, or if he has a minor playground bump and bruises, no change to steroid is needed. Obviously, you will monitor the condition of that young person. So minor illness, green, no change to your usual steroid regimen is needed. Next slide, please. Yellow, we're talking about moderate illness. And in a moderate illness, this is an acute illness, and usually the young person's hot, feeling hot, little bit miserable, generally not well enough for you to want to send him to school, or he's not miserable and doesn't want to go to school or college, but it's not too sleepy. He's getting by okay. Vomiting and diarrhea illness, provided he can keep his oral meds. And in this instance, it's when you need to think about an oral steroid sick day dosing, which, as I say, either in the form of hydrocortisone about 4 times a day, some centers do 3 times a day for the duration of the illness, or prednisolone given twice a day to ensure that there is steroid covering over the 24-hour period. Generally, what we would say is that if the condition's not starting to improve after 48 hours of you managing at home with stress days dosing, you may want to contact your medical team just to make sure that that's just a simple viral illness, it's not, and not something else. Next slide, please. With severe illness, so we're coming to red. So it's an acute illness where the boy is sleepy and drowsy. But as already a couple of people have said, and I think Michela, if you're worried, go with your gut instinct. Okay. Other situations, like obviously that hopefully that doesn't happen, a road traffic accident, some kind of a head injury where there's some concerns of loss of consciousness or actual loss of consciousness, a long bone fracture or suspected long bone fracture where either you can see some clear deformities or the young person is in a lot of pain. In that instance, you need to think about a hydrocortisone injection, either administered by yourself if you're trained, but also or by the attending paramedic or hospital staff. And remember, the key terms are steroid dependent, or use the word adrenal insufficiency, and that you're worried that he's having an adrenal crisis. As already said, that some doctors do not know that deflazacort is a steroid, and certainly if you're in vamorolone, they will not know that, and you will need to equip them with that information. Next slide, please. So green, mild, moderate, severe. Hopefully you've now got a better idea of what to do with steroid sick day dosing, and it's clear. Happy to answer questions at the end. And I think my final slide really talks about some of the information that we've developed as part of DMD Care UK, which is a bracelet for emergency, the app, which has already been mentioned, and Kathy will talk about more, a leaflet on adrenal insufficiency, but also if you wish to find out a little bit more about steroid stress dosing and adrenal insufficiency, we held a specific stress dosing webinar about a year ago, which is on the DMD Care UK website, but also on the Duchenne UK YouTube channel. It is an hour long. I talk through certain more scenarios, and there is also a demonstration on how you perform an injection for you to revise if you've been trained. And that ends my talk, and thank you very much for all the people who've worked on this excellent project, and to Kathy now.
Thanks, Jarod. Shall I just jump straight in? So thank you very much for both those presentations. I think that it sound to me like that's really, really useful and vital information. I'm just going to take a couple of minutes and leave plenty of time for questions, if that's okay, to just show you very briefly the app that we've been talking about several times on this webinar already. So if we go to the next slide, please. These are some examples of other, yeah, there we go. So the Duchenne UK in case of emergency app was launched several months ago, and it can be downloaded to be installed onto a phone, either your phone or a person with Duchenne's phone if they're old enough to have their own and be relatively independent. And into that app, you can input information about yourself or about your child, which is specific to them. So if we could go to the next slide, please. Within the app, you're asked to enter information such as the medical team details, so that you have within that the contact details for your neuromuscular consultant, for your cardiologist, for your respiratory expert, and so on. Whether or not, for example, you're on any clinical trials, as Michela alluded to before, because that's important information in an emergency. Contact and family details for parents, carers, anyone else that you want to put into there. Next slide, please. And then the clinical information that you put into the app will sit on the phone, either the patient's or the parent or carer. And that has information, for example, about any allergies the person might have, their steroid dosage and regime, any other medications that they're taking, their most recent weight measurement, respiratory status, whether or not they have cardiomyopathy or any cardiac preventative drugs that they're on, gastrointestinal issues, comorbidities, for example, diabetes, social communication difficulties. So if you or your child has ADHD or autism, sorry, then that can be put in there as well. And also the option to upload medical reports. It's not it's not a sophisticated system. It's quite simple and easy to use. You take a photograph of your most recent medical report and you upload that as a file into the app. Next slide, please. And then what the app does is it brings together, based on the information that you've put into it, all of the vital information that might be needed in an emergency that Michela and Jarod have just talked through, so that it is in the form of a PDF. I've just taken a screenshot here, and this is just a dummy entry, so apologies if I've put any silly things, silly figures in here, but it creates a PDF that's bespoke to that person with Duchenne. And that PDF can then be pushed to an email address. You can push it to your own email address or to your child's school, their grandparent, the parent of a friend that they go around and play, you know, if they go around to their house frequently, and that can then be printed off. So that's one way it can be used. You can print off a hard copy of the PDF that the app generates and keep a copy of it in the file at school, for example, as I say, at your grandparents' house, whatever it might be. But also in an emergency situation, and this is where we've heard that it has been used already. Can we just go to the next slide, please? I think it's just a further screenshot. Yeah, so that you can see there the kind of information that it generates. you can email it in real time to an attending physician. So if you're in A&E and you have a doctor says, okay, yes, I want to see that information in an app. If you haven't got the hard copy printed out, you can send it by email to him or her in real time, and they can view it on their phone. Of course, the information can be viewed on the person's phone as well, the person with Duchenne or their parent or carer. Next slide, please. So you can download the app it's now available on Android and Apple. We had some, it was a slight delay in getting it launched onto Apple. I should say that we are working on a revised version with many improvements. There are improvements that need to be made. And we're taking feedback on that through a survey that you should have received by email from Duchenne UK. That information is really, really valuable to us, because when we do a second build of this app, there are lots of things we want to improve and change. It's still very useful at the moment. The feedback we've had has been that it has proved useful in emergency situations, but the improved version will be as good as the feedback that we get, really. So please do fill in that survey, and it will help us to improve it further. Next slide, please. Oh, sorry, that was my last one. So you can find a link to the emergency care app on our website, DMD Care UK. I should say that any data that's entered is stored on the phone. It's not cloud-based at the moment. That's one of the things we're looking at changing in the next release. But at the moment, any data that you enter is held solely on that phone. We don't have any access to that data. I just wanted to finish off because Michela mentioned something about psychosocial care, and I will be highlighting this. We don't have time within this presentation, but we are doing some work on trying to generate psychosocial standards of care within DMD Care UK, and providing increased access to clinical expertise and addressing some research questions as well within the project. If you're interested in that, you can contact me afterwards or have a look on our website. So I'll stop there and hand back to Alex for any questions. Thank you.
Oh, thanks, Kathy. And I know from my own personal experience, the app has just been a godsend. So I really, if you haven't downloaded it, I really recommend downloading it. So we've got some questions that have come in. The first one is, if you are taking steroids 10 days on and off, presume you increase to daily, but does the dose need to be twice daily? I don't know if Jarod, you can answer that question.
Sure. There are probably a few ways of doing it. Depends on which steroids you're on. Prednisolone, deflazacort, is fairly short acting, and prednisolone probably doesn't last the whole day as well. So what I do in Glasgow is that I give every child hydrocortisone 4 times a day, and that is despite the type of steroid, despite the regimen. So if your boy is managed by our clinic, and regardless of whether you're on the 10 days on or 10 days off, you take hydrocortisone 4 times a day for the duration of the illness. But some clinics would recommend giving prednisolone twice a day. So ideally, if it's stress dosing with prednisolone, you should be taking it twice a day. But do speak to your medical team about what the approach is.
Great, thank you. And then another question, would the consultant provide you with the oral hydrocortisone, or GP? Would you keep the supply at home?
Again, I can give my experience, and I believe there might be some slight differences with NHS England. We tend to initiate the treatment, but we ask the doctors, the GP, to issue it on repeat, basically, the IM hydrocortisone vials and also oral hydrocortisone. But I believe this might be slightly different in NHS England, and that perhaps the neuromuscular clinician might have to continue to initiate that or prescribe that. Michela, maybe you could comment.
Yeah, I think that these really depend on where you live and what is the agreement. In general, you might need a prescription from your consultant, but then the GP will provide the oral hydrocortisone. It's just because the consultant might not be able to prescribe it directly because of hospital agreement. So they just ask the GP to prescribe the hydrocortisone. The other things you can do is to ask the GP, and if they have any concern, to ask the consultant, the neuromuscular consultant, to confirm the need, or the endocrinologist if you are under endocrine team. So depend a little bit of who is, if there is an endocrine team already involved in the care of the patient, usually it's the endocrine team that can prescribe it directly. But the important thing is you alert this. It's not a very expensive drug, usually is not an issue to have it. The GP might just need a neuromuscular specialist or an endocrinologist to confirm why you need it.
Yeah. Another thing, just from my own personal experience, is to just keep an eye on what the expiry date is on the injectable hydrocortisone vials, because they do expire. So just be mindful that, you know, that they haven't expired. I think ours usually last about a year, and then I have to ask for a new repeat prescription. And then we've had another question. Should you speak to someone before you decide to give your son hydrocortisone? Is a mild or moderate?
So again, my approach is that we give very clear instructions on when you should give oral hydrocortisone or when your injection. So specifically, you don't have to, but again, depending on what you've been advised. But of course, some people do sometimes follow up with a phone call with us just to say that, you know, I've been giving him a stress dosing oral hydrocortisone, but I just want to check that's all I'm doing. Now, if you've given an IM dose, an injection dose, we tell people to present to hospital, just because that sounds like a severe illness. Hydrocortisone lasts for a very short while, so you are quite likely to see quite good improvement over a couple of hours, but he might deteriorate. So we tend to advise, and in fact, the British Society of Paediatric Endocrinology and Diabetes new guidance suggests that you need to present to the hospital and they need to be observed for about 4 to 6 hours just to make sure that they're stable. But of course, if you've been asked to speak to your doctor, please continue to do that.
Okay, we've had
If
another.
I can add a comment here, is that Jarod, again, please confirm that you agree, because sometimes is the situation and you cannot get in touch with anyone. And I think that it's important for the family to understand that giving a extra dose of oral hydrocortisone is not dangerous. So in doubt, it's better to give it instead of not giving it. So I wouldn't wait to be able to get in touch with someone if you feel is not well. Obviously, if symptoms persist, you definitely need to get in touch. I agree, if it's an IM is different, but it's just to say, it's not something that is better to give it than just wait or not giving it in case it is needed.
And just to follow up on that, same thing with an IM as well. If you do think you need to give it and you have been trained, although the IM dose is much higher, but 100 milligram dose of IM hydrocortisone is roughly equivalent to about prednisolone 25 milligrams, which is effectively what some boys with Duchenne are taking anyway. So don't worry about that, you know, as long as you're not doing it every day or every second day, of course.
Okay, great. And then another question. My boy just started with 6 milligrams of Deflazacort with 10-day on and off. How to identify if any stomach pains? He has communication difficulties. I don't know, Michela, if you can answer this one.
Sorry. No, I think that it's in general, I would say, his symptoms are usually either before when on an empty stomach or soon after having received some food. So if the boy complain about just this, they might not point it out that exactly the localization of the pain. But if you see that he's not behaving himself, he's just very agitated, he's just in general upset, even if you do not know exactly when, either before a meal or after the meal, I would say, especially if they have communication difficulties, ask to be seen by a GP. Indeed, in the GP, they just put a hand on the tummy and they can say if there is a sign that suggested a possible gastritis or a gastric ulcer. So a physical examination can definitely detect the presence. So if you have any concern about, I'm not really sure, but it's quite a good pathway that is around the mealtime, ask to be seen.
And then we've got another question here. Is there no difference with vamorolone? I'm wondering if it's meaning risk of adrenal crisis. do we manage that differently with if you're on vamorolone?
I might start and Jarod continue in a way. I think that obviously the evidence regarding vamorolone are more limited compared to experience that we have with prednisone and deflazacort. But we need to remember that vamorolone is still a steroid-like drug. The evidence is that we have obtained from the clinical trial that has been run so far seems to suggest that also vamorolone causes adrenal insufficiency. And this is particularly is very similar to prednisone on the high doses of vamorolone, 6 milligrams, might be slightly less with lower doses, but it's something that probably also reflects traditional corticosteroid. So to play on the safe side, we always said that even if you are on vamorolone, you are at exactly the same risk of adrenal suppression, and therefore all the stress dose rules apply. The only difference is that with vamorolone, because it's a less known drug, we try to say that if you need a stress dose, should always be with oral or IM hydrocortisone, and we can't really play too much in saying of doubling the dose of vamorolone because we know it less. Saying that, if you don't have hydrocortisone and you only have vamorolone and you have that concern, I think that we need to use common sense and do what the best that we can do.
Yeah, I think so. I think you know, only a very small handful of boys in the UK are on vamorolone as part of the clinical trial, right, Michela? And I think as part of the clinical trial, the sick day dosing plan is with the hydrocortisone plan anyway. So if your son is on vamorolone, I would have thought that hydrocortisone is part of the plan already.
Okay, great. I think Michela's answering some other questions that are coming in. Just from my own personal experience with Jack last week, he did vomit. We did manage to get his steroids into him, but we had to give him some anti-sickness medication, which we then kept up. Do you find it helpful to give anti-sickness medication if the boys are feeling sick, so you're getting the steroid dose down?
I can say what I do. So I know that there's some pros and cons of giving it out routinely, I think. So I tend to give the anti-sickness to boys starting first dose of bisphosphonate infusion and ask the families to actually give it to them if they feel nauseous, to prevent the vomiting and that they can keep the steroids down. In an acute illness, I guess sometimes, you know, you're a little bit hesitant because you don't know how ill they can become. So, but I think there's no hard and fast rule, I would say. And Michela, maybe you want to actually comment. I think it's a difficult call. I think, Alex, it looks like it works very well. Yeah.
Yeah, I agree that, I mean, the anti-sick medication, we need to understand a little bit why a child or a person is sick. And it's not just, I'll give you the sick medication, I give you steroid and it's fine. And for my experience, it's rarely like that. If you cannot take the steroid, you cannot take the sick medication. Saying that, obviously, if a patient is persistent vomiting, reason for which you cannot take oral corticosteroid, in that case, quite often, even the IM is not enough if the vomit is severe enough. Therefore, will need to be admitted for a hydrocortisone IV. And when we treat with the hydrocortisone IV, in that case, we might also suggest to associate a anti-sickness drug that is usually the ondansetron, but is done under monitoring, not just as a fix the problem and stay at home, if it makes sense.
No, that's great. I don't think we've got any more questions. If anybody has got any questions, please, you know, get in touch with us and we can forward on any questions. So yeah, please send us an email. So I think that's everything for tonight, so we can conclude the webinar. Thank you so much to everybody who's taken part. We really, really appreciate all your help, and I just want to acknowledge all of the working group members who give their time so generously, our family focus group who keep us focused on what we need to do, the North Star Network, our steering committee, the project team at Duchenne UK and Newcastle University, and the funders, Duchenne UK, Duchenne Research Fund and Joining Jack. So thank you everybody for taking part.